4 months. That is how long Dr. Jonathan Reyes had been using the word probationary like a hammer and her name like an afterthought. 4 months of public corrections in front of staff who kept their eyes down, of chart reviews that went wrong on purpose, of extended probationary cycles with no documented cause. The other nurses watched. The residents watched. Nobody pushed back. At Prescott Level 1 Trauma Center, the chief of trauma surgery didn't get corrected. She took the hard assignments without complaint. She clocked out quietly. She gave him nothing he could use. Until the afternoon, a man walked into Bay 6 with chemical residue under his fingernail, and a jacket zipped to his collar in a 72-degree room, and she recognized the smell coming off his clothes before she had even finished taking his blood pressure. She flagged it. Reyes laughed at her in front of the floor. Then 2 suspicious packages appeared at the hospital. The bomb squad was called, and the woman who had been treated like a first-week student for 4 months started giving render-safe guidance over the radio that no nurse in any training program on Earth would know. Stay until the end of this story. If it stays with you, hit like and drop a comment telling me what city or country you're watching from. Subscribe so you never miss a story like this one. The chart was wrong. That was what Dr. Jonathan Reyes said, loud enough for the entire nursing station to hear, his voice carrying the particular edge of a man who had decided to make something into a lesson and was enjoying the deciding. This is a 4 milligram dose. He held the chart up, not toward Claire, toward the room, toward the 2 nurses, the tech, and the first-year resident who had all been minding other things and were now minding this. The standing order is 2 milligrams in pediatric cases under 30 kilograms. He let that land. Do you want to tell me what would happen if this had gone to pharmacy unchecked? Claire Halton was standing 3 feet from him at the nursing station. 4 months on this unit. A probationary badge under her hospital ID. The particular deliberate stillness of someone who had learned a long time ago that stillness was not the same as submission. It just looked like it. Sometimes that was useful. The patient is 37 kilograms, she said. The order is within adult dosing parameters. A silence that lasted precisely as long as Reyes needed it to. He looked at the chart. He looked at the patient weight on the intake form. He looked at Claire with the expression of a man who has been caught and will not be acknowledging it. Document your rationale, he said. Thoroughly. He walked away. The nursing station returned to its working sounds the way rooms return to sound after something has happened that everyone has recorded and no one will name directly. Sandra Maves appeared at Claire's left shoulder. Sandra was the charge nurse, 47 years old, and had been running this floor for 11 years with the quiet authority of someone who had seen every variation of every dynamic and had decided long ago that the most useful response was documentation, patience, and the occasional word in the right direction. He's wrong, Sandra said, without looking up from her tablet. I know. He knew before he finished the sentence. I know, Claire said. Sandra made a notation. That's the 2nd incident this month, 3rd in 6 weeks. He extended your probation last Tuesday on a chart entry timing complaint. 11 minutes. I know. Sandra looked at her. What did you do before this? Claire picked up the next chart. I'm a nurse. I took a job. Prescott Medical Center was a Level 1 trauma center, which meant it absorbed the city's worst. The cases other hospitals redirected, Prescott took multi-vehicle accidents, industrial injuries, gunshot wounds, pediatric traumas, cardiac emergencies arriving by helicopter and ambulance, and occasionally, on foot. The ER ran 42 beds at a constant controlled pressure, the kind of sustained intensity that separated the staff who stayed from the staff who transferred within a year. Claire had been here 4 months. She had worked carefully to be forgettable. She was 34 years old, lean and angular in the way of someone for whom physical discipline had stopped being a choice and become structural. She kept her dark brown hair in a tight, low bun under her scrub cap. She kept her sleeves down regardless of room temperature. She moved at precisely the speed the situation required, never faster, which read from the outside as modesty or caution. It was something else entirely. Dr. Yemi Okafor, the first-year trauma surgery resident, appeared beside her at the supply cart. He was 29, technically excellent, and had the expression of a man who had witnessed the exchange at the nursing station and wanted to say something useful and was calculating whether he could afford to. "You were right," he said quietly. "About the dosing." "I know." "The order was correct." "I know." He looked at her with the frustrated precision of someone trying to understand something that 4 months of proximity had not resolved. "Doesn't it bother you? Any of it?" Claire checked the IV bag she had come to replace. "Which part specifically?" "All of it." His voice stayed low. "He does this every week. He picks someone. You've been the someone for 4 months. Most people crack or leave. You just..." He paused. "You don't. Why don't you?" She unseated the old bag and connected the new one. Her hands moved through the procedure with the efficiency of someone for whom it no longer required full attention. "Because cracking is what he wants," she said, "and leaving is what he needs." She closed the line. "Bay 4 needs a central line assessment. He'll be by in 20 minutes. Okafor took the hint and moved. It had been this way since the first week. Reyes had looked at her intake form, at the employment gap she had listed as personal leave, at the vocational nursing program she had completed in the 16 months before she applied. He had formed a conclusion. In the 4 months since, he had been maintaining it the way certain people maintained conclusions, not by re-examining the evidence, but by accumulating additional evidence against the alternative. She had made 2 charting errors in 4 months. Both had been his errors, attributed to her. Both had been documented in a way that made the attribution credible. She had not contested either one. Contesting them would have required explaining herself. Explaining herself would have required disclosing the gap. Disclosing the gap would have ended this. And ending this before she was ready was not an option she was willing to take. She moved to Bay 6. The patient in Bay 6 had arrived as a chest pain presentation, moderate priority, self-transported. His name was Alan Dorsey, 43, no cardiac history on file. Onset of pain approximately 40 minutes prior to arrival, left arm radiation, diaphoresis noted at intake. His troponin was pending. He had been placed and attached to the monitor and told someone would be in shortly. She pulled the curtain aside and went in. Dorsey was seated on the edge of the gurney, in the way of a man who had made a decision to come here under pressure he was not describing. He was heavy-set, mid-40s, dark hair, wearing a gray fleece jacket zipped to the collar. The room was 72 degrees. The jacket had not come off. The jacket first. Zipped to the collar in 72-degree air. His color was off. Not the clean pallor of genuine cardiac distress, but something more complicated, uneven. Pale in some places, flushed in others. His hands were in his lap and she looked at them. He had washed them recently. The cuticles were tight. The knuckle ridges chapped from soap applied with effort. Under the nail of his right index finger, there was a dark residue, granular, catching the light at the angle of something that did not belong there. All 3 noted. Her face stayed neutral. "Mr. Dorsey, I'm Claire. I'm the nurse assigned to your care this afternoon. How are you feeling right now?" "Chest pain," he said. "Like I said at the desk." "Can you describe it for me?" "Pressure, sharp, squeezing." "Pressure." His hand went to his sternum, center left. The gesture was anatomically correct. It was also practiced. "Scale of 1 to 10. 6, maybe 7. When did it start?" "About an hour ago. Maybe more." She put the pulse oximeter on and started her secondary assessment. Blood pressure 158/94. Elevated, consistent with pain or anxiety, and also consistent with a number of other things. Lungs clear. Heart sounds regular, no murmur. Respiratory rate 16, slightly elevated. He was watching her work with the too careful attention of someone monitoring a clock he had not mentioned. Standard questions. Medical history. Family history of cardiac disease. Yes, his father. Delivered quickly. The way prepared answers are delivered. Current medications. None listed. She stepped back and let her attention move across the bay in the way it had been moving across enclosed spaces since 2014. Exit points. Object placement. Anything asymmetric. A habit trained into her before she had fully understood what it was for, and one that had never fully untrained itself. The jacket was zipped to the collar in a 72-degree room. The residue under the fingernail was dark and granular, and she noticed the smell. The ER had its own chemical register. Antiseptic, cleaning compounds, the low metallic note of blood, the industrial smell of the ventilation. This was underneath all of that, faint in the way of things that should not be present. Sweetish and synthetic. An acetone note, but wrong, not cleanly acetone. Something sharing acetone's base while being something else entirely. She knew that smell. She had known it in Mosul in 2019 in a concrete corridor behind a water filtration unit, the smell preceding the device by 30 feet. She had known it in Kandahar in 2018 before the team lead called it, and she had already named it. She had known it in 3 separate deployment contexts, in circumstances she did not discuss, and would not discuss in this room or any room in this building. TATP, triacetone triperoxide. Primary explosive synthesized from acetone and hydrogen peroxide. Unstable by design. Specific in its chemical signature. Favored by inexperienced builders for its accessibility, and by experienced ones for its reliability in initiator applications. She completed the assessment form. She pulled the curtain closed behind her. At the nursing station, she went to Sandra. Bay 6, she said, at conversational volume. Chest pain presentation. Run the full workup. Already ordered, Sandra said. Also. Claire kept her voice under the ambient noise. His jacket is zipped to the collar. He has dark granular residue under his right index fingernail. There is a chemical smell in that bay that I recognize specifically. Sandra looked up. Not a guess, Claire said. I know what it is. I know the context in which I've smelled it before. She paused. If I bring this to Reyes, he will use it. So I'm telling you first. Sandra held her gaze for 2 full seconds. What is it? A precursor compound for a primary explosive. The signature is specific enough to identify the class. You're certain? Yes. The way I'm certain about a drug dosing calculation. I've smelled it in context and I know what it is. Sandra looked at the bay, at the curtain, at the floor continuing its normal register around them. I'll contact security. Don't make it visible. His workup is legitimate. Blood pressure elevated, diaphoresis present. He may have a genuine cardiac situation alongside whatever else he is. She picked up a chart. Security needs to know. But quietly. Sandra reached for her radio. Claire went to Bay 11. Thomas Garrett, 67, was in Bay 11 with a hypertensive crisis that had finally come down to range. He was wearing a faded Army veteran's hat and watching a military history documentary on his phone with the sound off. His blood pressure on arrival had been 192/108. It was 141/86 now, which was where it needed to be to think about discharge. Mr. Garrett, how are we doing? Ready to go home, he said. My wife has been in the parking lot for 2 hours. Consultation was pushed back about 40 minutes. I'm sorry about that. She's going to have opinions. Tell her the delay was mine. I'll deal with her directly. He smiled at that, then studied her in the way older veterans studied younger people, not assessing a threat but reading something more specific. You have a look on your face, he said. I have 17 patients. That's not what I mean. He turned his phone face down. Problem-solving look, the kind where you can't say it out loud. She checked his pressure, 138/84. Good. Army? He said. She looked at him. My son is Army, medical. Something about the way you move. He shrugged. You get a sense. Whatever is on your mind, he said. "You know what to do about it." "I'm a nurse," she said. "I take care of patients." "Sure," he said. "That too." She finished his documentation and moved back to the floor. Sandra was at the desk. She caught Claire's eye once and gave a brief nod. Security had been called. A different officer than the first pass. Sandra had made a second contact after the initial check came back clean. Claire went to Bay 7. The pediatric case in Bay 7 was a 6-year-old named Maya with a playground laceration above her left eyebrow. The laceration had been sutured and was clean. Maya had been crying when she came in, but was not crying now. She was sitting up with a sticker the triage nurse had given her, and her mother was beside her with the specific exhausted relief of a parent who has received the word that her child is fine. "Everything looks good," Claire told the mother. "The suture will dissolve on its own. Keep it dry for 48 hours. Follow up with her pediatrician in 5 days." She went back to the floor. Sandra put the radio down. "Jeff says nothing of concern." Jeff wasn't looking for the right things. Sandra turned to face her fully. "What are the right things?" "TATP," Claire said. "Triacetone triperoxide, primary explosive. The chemical signature is specific. Acetone adjacent, but with a sharper secondary note underneath. Once you've encountered it in context, you don't confuse it with anything else." She kept her voice at the level of normal conversation. "The residue under the fingernail is consistent with handling granular material after washing. The jacket at 72 degrees means he's either concealing something on his person or preserving the smell on his outer layer." Sandra was very still. "How do you know what TATP smells like?" Claire picked up the next chart. "I've encountered it before." "In a nursing context?" "No." A 4-second silence. "I'm making a second call," Sandra said. "Different officer. One who knows what to look for." She turned back to her desk. Claire worked her patients. She was at Bay 2. An asthma exacerbation, 41-year-old woman, sat climbing steadily in response to the nebulizer treatment, when she heard a change in the quality of sound from Bay 6's direction. Not loud, not alarmed. The specific, controlled quality of someone managing something. She moved to the corridor. From there, she could see Bay 6, the curtain half open, Dorsey standing at the edge of the gurney, both hands on his phone. The screen was live, the blue light visible from 20 feet. He was not making a call. He was reading something with his jaw tight and his shoulders raised. She watched. His expression resolved. The jaw settled. The specific settlement of someone whose pending decision has become a completed one. A tension releasing that is not relief, but commitment. He put the phone face down. He did not look at the corridor again. Back at Bay 2, she finished the asthma assessment with her hand steady, her mind doing the calculation she had been trained to do when she recognized that specific behavioral shift. The phone had been dark for 30 minutes, and suddenly active. The activity ended in a very specific way, the class of device that paired a cellular trigger with a mechanical backup. She knew that class well. Just a nurse. At 5:33 p.m., Sandra's radio crackled. Security at the loading dock. Suspicious package. Unattended bag in the staff delivery area. A receiving tech had flagged it. Sandra picked up the radio. Her face gave nothing away. She was already looking at Claire. Claire was already looking at Bay 6. The ECG on Alan Dorsey came back at 4:47 p.m. and showed nothing actionable. No ST elevation, no bundle branch changes, no ischemic pattern. Sinus rhythm, rate of 88, slightly elevated but consistent with anxiety or pain. His initial troponin was borderline, 0.042, just above the normal cutoff, which in a chest pain workup meant repeat testing in 3 hours, not emergency intervention. Dr. Reyes reviewed the ECG at the nursing station. He looked at the rhythm strip for 8 seconds with the practiced attention of a man who had been reading cardiac rhythms for 25 years. "Atypical presentation," he said to Okafor. "Demographics and family history put him in the cardiac risk category. Left arm radiation, diaphoresis on presentation. We run the standard workup, Repeat the troponin at 7:47. Get a cardiology notification in the morning. Textbook. He handed the chart back. He had not looked at Claire. She was at the supply cart 12 feet away, preparing a medication draw for Bay 11. She heard every word. She noted the things he did not say. He had not addressed the jacket. He had not noted the smell. He had not commented on the presentation as anything other than a straightforward cardiac concern. Sandra's second security contact had come back clean. A different officer, more thorough than Jeff. He had pulled the curtain, introduced himself as routine safety protocol, scanned the bay, noted the jacket and the slightly guarded manner, attributed both to patient anxiety, and left. He had filed a note that said in several more words, the same thing Jeff's had said. Nothing of concern. Claire knew what that meant. It meant the officer had not known what he was looking for. It meant the concern was still present and had simply not been seen. Those two things were not the same. She went back to Bay 6. Dorsey had accepted the second ECG lead placement without objection. He was lying back now, jacket still zipped, watching the monitor with a focused outward attention that was not the inward monitoring of a man tracking his own symptoms. He was watching the numbers with the externalized attention of someone reading a clock. "How are you feeling?" she asked. "Same," he said. "Any change in the pain?" "Maybe a little better." He pressed his hand briefly to his sternum. "That's consistent with how the medication works." She checked the lead adhesion on his left arm. Lead 2 had partially lifted. She reseated it. "Can I get you anything? Water, something to eat?" "I'm fine." He was watching the window to the corridor. His phone was on the mattress beside him, face down. Patients typically spent their first 30 minutes in the ER cycling through attempts to find signal, texting updates to family, searching their symptoms. Dorsey had not touched his phone in 30 minutes. "Is your signal okay in here?" she said casually, adjusting the monitor cable. "Some rooms in this wing are better than others." He looked at the phone, a quarter-second delay before the answer. "It's fine." The delay told her what she needed. She left. At the nursing station, she opened Dorsey's chart and typed the nursing notes. She wrote them with clinical precision. The smell. An acetone-adjacent compound with a specific secondary note. The granular residue under the nail. The jacket inconsistency. The behavioral indicators. Attention directed toward the corridor. Phone unused for 30 observed minutes. Answers delivered with the cadence of prepared responses rather than spontaneous recall. Both security contacts. Their outcomes. She saved the note. She saw Reyes coming before he reached the station. He had a habit of approaching from the surgical corridor when he wanted to arrive without announcement. She had been watching for it. He read the note for 12 seconds. "This will be removed," he said. "It's a clinical observation. It's speculation dressed in clinical language." He kept his voice low and level. "You're documenting a smell and a patient's clothing preference as a security concern in a medical record. For a patient with a normal ECG, a borderline troponin, and 2 security visits. Both security visits were superficial. Neither officer found anything. Neither officer knew what to look for." He put the tablet down. He looked at her with the full attention of a man who has decided that the indirect approach is no longer sufficient. "Do you know what this documentation looks like?" he said. She waited. "It looks like a probationary nurse creating a paper trail for a verbal concern that nobody validated. It looks like defensive documentation masquerading as clinical observation." He paused. "And it is exactly the kind of clinical judgment problem that has extended your probationary status." "So you're deleting a documented safety concern from a patient's chart," she said. "I'm removing speculation from a clinical record. And if I'm right, you're not." He deleted the note. He set the tablet back on the counter. He walked toward the surgical corridor. The nursing station held its silence the way it had been holding silences for 4 months. Okafor was at the whiteboard, with his pen on the same line he had been updating for 2 minutes. Sandra was at the far end of the desk, moving papers that did not need to be moved. Claire picked up the next chart. The rotation continued. Bay 2. The asthma patient. Sat at 97 now, breathing easier. The treatment doing its job. Bay 7, Maya. Discharge paperwork nearly complete. Bay 9. Post-procedure observation. Uncomplicated. Bay 11. Garrett's consultation delayed again, his pressure holding at range, his patience holding better than hers would have. Efficient, thorough, and quiet. Her documentation carried the precision that Reyes had just confirmed. In the process of explaining why it was a problem, was accurate, thorough, and correct. The quality of sound from Bay 6 changed while she was at Bay 11. Not an alarm. Not a voice raised. The specific controlled sound of someone managing something on a timeline. From the corridor, she could see Dorsey standing at the edge of the gurney, the curtain half open, both hands on his phone. The screen was live and active. He was not making a call. He was looking at something on the screen with his jaw tight. She watched him for 4 seconds. He looked up at the hallway, looked at his phone, looked at the monitor behind him, his expression resolved. The specific resolution of someone whose pending thing has become a completed thing. He sat down on the gurney. He put the phone face down. He did not look at the hallway again. Back in Bay 11, she finished Garrett's documentation with her hand steady. Her mind was running the calculation she had been trained to run when she identified that specific behavioral shift. The phone had been dark for 30 minutes, and then suddenly active, and the activity had ended in a very specific way. She knew what kind of device used a cellular trigger alongside a mechanical timer. Just a nurse. At the nursing station, Sandra's radio crackled. Security at the loading dock. Suspicious package. Unattended bag in the staff delivery area. Flagged by a receiving tech who had done his training correctly. Sandra picked up the radio. Her face gave nothing. She was already looking at Claire. Claire was already looking at Bay 6. And then she was looking at Dorsey's chart. And then she was looking at the monitor in the bay. His heart rate, which had been 88 40 minutes ago, was now reading 104. His heart rate was climbing. Both things could be true at once. She had learned that a long time ago. She had also learned that both things required attention simultaneously, and that the person in the room who had the ability to provide that attention was the person who needed to be in the room. She was already moving toward the bay. The code silver came over the intercom 40 seconds after Sandra's radio crackled. Code silver. Code silver. All non-essential personnel are asked to proceed to designated safe areas. This is not a drill. At Prescott Level 1 Trauma Center, Code Silver had a specific protocol, and the staff moved through it with the contained efficiency of people who had rehearsed it quarterly and were now doing the real version. Non-ambulatory patients who could be safely moved went toward the interior. The corridors cleared. Security deployed full at the entrances. The minimum essential staff required to maintain critical patient care stayed in position. The ER transformed in under 90 seconds. Nurses in pairs toward the administrative wing, residents following their attendings, orderlies with portable monitors, the tech with the crash cart redirecting. Sandra at the desk, dispatching everyone with the clipped authority of a woman who had been the last standing person on this floor in emergencies before and would be the last one again. Local police, 6 minutes out. The EOD unit, a joint city-army bomb squad operating under a 2-year training exchange, was 3 minutes out. Claire was already in Bay 6. Dorsey had changed. The complicated pallor from his initial presentation had shifted into white-gray beneath the skin, the specific coloring she had seen in cardiac bays before, and never in circumstances that were not urgent. His hand was pressed flat against his sternum, not the placed gesture from earlier. Real pressure against real pain. His eyes were open, and tracking with the unfocused quality of someone managing severe internal sensation. She looked at the monitor. Heart rate, 108. It had been 88 45 minutes ago. She pulled up the repeat ECG she had ordered, which had printed at 4:58, and loaded it on the monitor display. ST elevation in leads 2, 3, and AVF. 2.3 millimeters in lead 2. Classic inferior territory. Right coronary artery, most likely, or circumflex in right dominant anatomy. Active inferior STEMI. Not atypical presentation. Not anxiety. Not a borderline troponin. A genuine, active myocardial infarction in a man who had simultaneously been carrying explosive precursor residue on his hands, and whose jaw had resolved in the specific way of someone who had confirmed that something was in motion. Both things were true at once. She reached for the phone to call the code team and then stopped. The code team was in the evacuation. The cath lab was on the 3rd floor and was being cleared. The on-call cardiologist had not yet reached the building. She looked at the doorway to the bay, staff moving past in controlled pairs. She made the assessment the way she had always made assessments. Fast, specific, based on what was actually in front of her. Dorsey could not be moved to an evacuating cath lab. He could not be transported to another facility in active inferior STEMI without intervention. Thrombolytics were indicated. They were available. They were within her scope if authorized by the appropriate physician. She picked up her phone. "Sandra," she said. "His repeat ECG shows inferior STEMI, active. He cannot be safely evacuated. I'm staying in Bay 6. Claire, I need the crash cart and the thrombolytics tray. Whatever's still accessible on the floor. The bomb squad. I know, the cart." She hung up and went back to Dorsey. He looked at her when she came in. The fear in his eyes was real, the specific fear that belongs to people who have been managing one situation and have now discovered that the situation has developed a consequence they were not expecting for themselves personally. "Am I having a heart attack?" he said. "Your ECG suggests an active cardiac event," she said. "I'm going to work on stabilizing you. I need you to stay as calm as you can and keep breathing." He put his head back. "What kind of nurse stays during a bomb threat?" "The kind who has 2 IVs to start," she said. "Give me your left arm." She had managed resources in worse conditions than this. She had managed in a compound in Mosul with 1 qualified medic and 2 personnel who had basic first aid training, 3 casualties, and an active threat in the outer corridor. She had managed in Kandahar in the dark, with equipment that had taken partial blast damage and a team that was down 1 qualified member because the terrain had required a split approach. She had managed once in a C-130 at altitude when the aircraft medic went down with altitude sickness, and she was the most qualified person on the bird. This was a bay, with a monitor, with equipment, with a physician who had stopped in the doorway instead of evacuating. She could work with this. She had the second line in place in 40 seconds. She started the aspirin protocol and the nitro and checked both IV sites, patent, running. She reached for the thrombolytics tray Sandra had brought to the doorway and set down on the supply cart. Dr. Jonathan Reyes was in the corridor. He had his jacket and his phone and the appropriate, purposeful movement of a man responding to an evacuation protocol. He had stopped at the open curtain of Bay 6 because the patient he had assessed as a standard chest pain workup was still in the bay with a nurse who had not evacuated. He did not come in. He stood in the doorway. She looked at him once. "I need you in here, or I need you out of the doorway," she said. "One of those." A pause that lasted 3 seconds. He came in. He stood at the foot of the gurney and looked at the ECG on the monitor. She watched him read it. She watched the precise moment when his face registered what was there. "That's an inferior STEMI," he said. "Active. 2 lead confirmation. 2.3 millimeters in lead 2. She was drawing the heparin flush. "He cannot be moved until this is stabilized. The cath lab is evacuating." Reyes looked at Dorsey, at the monitor, at the thrombolytics tray. "Mr. Dorsey," she said, "I need to talk to you about the packages." He looked at her. "The bomb squad has been called," she said. "They are going to find the one at the loading dock, but I need to know if there's a second location." Dorsey's breathing was labored. His pain was at 8. The answer cost him something to produce. "Parking structure," he said. "Level 2, northeast corner, brown canvas bag, behind the pillar by the stairwell." "How long on the timer?" He looked at her. The look was of a man deciding whether to be surprised by what she knew to ask. 6 hours, he said. Armed 6 hours ago. She had her radio from the supply cart and was already calling security. She gave the second location, the timer status, the bag description, flat specific, 90 seconds. She set the radio down. Reyes was watching her. Talk me through the contraindications, he said. She looked at him. It was not the pedagogical register he had been using for 4 months. It was not the teacher-to-student framing designed to keep everyone in their assigned position. It was the voice of a clinician who needed information to make a clinical decision and was asking the clinician in the room who had it. She gave it to him. In protocol order, specific. No recent surgery. No hemorrhagic stroke history. No anticoagulant therapy. No aortic dissection on presentation. No absolute contraindications identified. He listened without interrupting. You noticed the smell this afternoon, he said. In Bay 6, on initial assessment. Yes. That was a specific identification. Yes. 3 seconds. Administer the TPA, he said. Standard weight-based protocol. She had the vial in her hand before he finished the sentence. She had the dosing calculated before she prepared the syringe. Through the wall of the building came the sound of the first military vehicle arriving in the east parking lot. The EOD team set up in the east parking lot in under 4 minutes. 3 vehicles, 2 trucks and a command unit, civilian bomb squad with Army EOD personnel embedded under a joint city military training program. Claire could hear them on the security frequency that had been patched to the bay intercom at her request, a request she had made with the specific shorthand of someone who knew which words got results and which ones got questions, and had used the former. She was managing 2 things simultaneously. She had done this before. The TPA was running at the correct rate, and she was watching Dorsey's ECG the way she had always watched critical timelines, with the full attention that looks, from the outside, like something less than full attention, because it does not announce itself. His rate was down to 99 from 108. His pain was at 6. The slope was moving in the right direction. Reyes had not left. He stood at the foot of the gurney watching the monitor, watching Claire, watching the 2 simultaneous operations with the specific attention of a man who had encountered something outside his existing categories and was in the process of building a new one. On the frequency, the EOD team leader was describing the loading dock device. Duffel bag, partially unzipped. Visible circuit board, commercial. 2 pipe components approximately 18 inches in length. He named the specific details in the flat, methodical tone of someone taking inventory under time pressure. Claire listened while she checked Dorsey's second IV site. She listened for the details that changed the category of what you were dealing with. The circuit board, commercial grade, not military, indicated the builder's access and training level. The pipe components told her the main charge was fragmentation-based. The partial unzip was either carelessness or a specific design decision related to the trigger mechanism. Then the team leader said it. I'm seeing a secondary timer. Backup circuit on the primary power source. Claire set down the IV flush. A secondary mechanical timer alongside the primary cellular trigger. That was a dual trigger device. A device designed to complete its function regardless of whether the primary trigger worked or was disrupted. It meant the builder had anticipated cellular interference, law enforcement countermeasures, or dead zones in a building's structural walls. It also meant the cellular activation had already occurred. The timer was now the only remaining control. She reached for the radio on the supply cart. EOD team, this is Claire Halton, Nursing Bay 6. I need your team leader on this frequency. A security officer came on. Halton, this channel is restricted. I know it is. Get me the team leader now. A pause. Then a different voice. Controlled, efficient. The voice of someone whose professional default was precision. Staff Sergeant Cho. Who am I talking to? Claire Halton. I'm in Bay 6 with the device suspect. He confirmed dual trigger configuration and gave me the second package location. The primary trigger was cellular. I have reason to believe it activated approximately 25 minutes ago. Your remaining control is the secondary mechanical timer. A silence that lasted 4 full seconds. Say again, Cho said. Primary cellular trigger activated 25 minutes ago. I observed the suspect receive and respond to a confirmation signal at that time. The mechanical timer is your only remaining control. On a device of this construction class, the timer lead is routed through the initiator housing before reaching the primary circuit. You cannot cut the primary circuit without isolating the initiator housing first. If you do, you detonate the device. The silence this time was the silence of someone deciding between two possible assessments of the information they had just received, that it was very useful or that it was very wrong. Both possibilities required the same response. Proceed carefully and verify at each step. How do you know the construction class? Cho said. I've seen it before. Where? Mosul, 2019. The same cell built 7 devices across 4 months with identical template parameters. Dual trigger, commercial circuit board, pipe fragmentation main charge, initiator housing with timer routing. She was watching Dorsey's rate on the monitor, 96 now, trending down. I was in the render safe team on 3 of those devices. I was in the debrief on the remaining 4. Another silence. What is your background? Cho said. I'm a nurse. Not with that knowledge, you're not. Get the initiator housing isolated before you approach the primary circuit. That's step 1. Confirm each step and I'll walk you through the secondary timer from there. She had a way of communicating under pressure that she had developed over years, in conditions where the radio was the only link between the team at the device and the people with the information. You spoke at the pace of transmission, not the pace of thought. You gave the next step before the person had fully absorbed the current one, because absorption lag was the margin that cost operations. Cho was working the same way. They fell into the cadence of 2 people with identical technical training operating on the same timeline. He confirmed before she finished describing. He asked exactly the questions she would have asked in his position. The communication was efficient in the specific way that mattered most, when efficiency was the difference between outcomes. She was watching Dorsey's ECG between transmissions. Rate 93. The TPA was working. The right coronary artery was yielding to the medication, the occlusion dissolving incrementally, the ST segments beginning their slow retreat from elevation. The inferior STEMI was being managed. Both timelines were moving. She was managing both. Okafor appeared in the doorway at the 14-minute mark. He had come from the evacuation point at Sandra's direction. He looked at the room. Dorsey on the gurney, the TPA running, Reyes at the foot of the bed, Claire between the chart and the radio, and he stood at the curtain not quite in and not quite out. Watch the monitor, she said to him. Tell me if the ST segments change by more than 0.5 millimeter in either direction. He came in and took the position she indicated. On the frequency, Cho said, I'm looking at the timer lead. It's labeled red and black. Don't touch the red, she said. A pause. Say again. The red lead is a false termination connected to the secondary initiator. It's a deliberate reversal designed to look like a wiring error on the primary timer circuit. The black lead is the actual timer. On this construction template, the reversal is always present. It's not an assembly mistake. The silence on the frequency lasted 6 seconds. You're telling me the standard approach kills the tech, Cho said. On this specific template, yes. How do you know the reversal is present on this device? Because I've seen it on 2 devices from this cell, and because it's in the construction template I reviewed in the post-deployment intelligence brief. The reversal was deliberate, inserted by the cell's device maker specifically to counter EOD procedures. She checked Dorsey's oxygen saturation. 98. Good. But I could be wrong. You need to visually confirm the lead routing before you act on anything I'm telling you. I'm looking at it now, Cho said. A pause. The red lead is not going to the timer housing. It's going somewhere else. Yes. To the secondary initiator. Yes. Another pause. Black lead isolated, moving to the primary circuit. She stood by. On the gurney, Dorsey opened his eyes. He had been quiet for the last 12 minutes. The pain had come down from 8 to 4, which was the TPA doing what it was designed to do. "The little girl," he said. She looked at him. "Bay 7, the one with the head injury. She was crying when they brought her through." He closed his eyes. "I didn't think about the hospital when I planned this. I was supposed to be home." "Don't talk," she said. "I need you to know that." "Right now, what I need is for you to breathe," she said. "Everything else is for later." He breathed. Reyes was watching from the foot of the gurney. He had been watching for 19 minutes from that position, and his face had the composition of a man who was standing in a room and seeing what was actually in it, possibly for the first time. On the frequency, Cho's voice. "Device 1 is clear." She looked at the ECG, rate 88, ST segment still elevated but flattening. The TPA needed more time. "Second device," she said into the radio. "Parking structure, level 2, northeast corner, brown canvas bag behind the stairwell pillar. The second device will have the same construction template as the first. The initiator housing routing and the lead reversal will be identical. Independent trigger on its own cellular number. Same subscriber account as device 1. We're rolling to the parking structure now," Cho said. "Hold on secondary device guidance until we have eyes on it." "Standing by," she said. The radio went down on the supply cart. She checked the ECG. Back to work. Device 2 took 22 minutes. The parking structure device was more complex. The independent trigger mechanism had a redundant secondary activation path, a configuration Cho said he had not seen before in that specific form. He described it without alarm, in the flat tone of a man encountering a technical problem he had not yet solved, but had every intention of solving. She walked him through it. The method was the same she had used on 3 devices in Mosul and 1 in Kandahar, and once in a training simulation at Eglin Air Force Base that had been designed to be harder than anything she would encounter in the field. The simulation designers had been wrong about that, but their difficulty had been useful anyway. The secondary activation path she described in the terms she had been taught. The isolation procedure in the order the protocol required. She listened to Cho's confirmation responses with the attention she had always brought to render safe communications. Calm, specific. Each step confirmed before the next was described. Not because she doubted him. Because the protocol existed for the cases where doubt was not yet the right word, but care still was. Meanwhile, the TPA continued its work. Dorsey's ST segments retreated toward baseline on the monitor, incrementally, the way clinical improvements happened, not in a jump, but in a measurable slope. His rate came down to 84, then 82. His pain moved from 4 to 2. The right coronary artery was reopening somewhere in his chest, the occlusion yielding to the medication, the specific quiet process of a clot dissolving, and a coronary beginning to perfuse again. Reyes stood at the foot of the gurney through all 22 minutes. He did not speak. He watched the ECG, and he watched Claire, and he watched the 2 simultaneous operations with the specific attention of a man who had stopped managing the situation and was now simply in it. Okafor remained at the monitor. He did what she had asked him to do, and he did it well, and he watched her work the radio between checks with the expression of someone who had been adding up observations for 4 months and had arrived, somewhat abruptly, at a sum. At 6:04 p.m., Cho's voice came through the frequency. "Device 2 is clear." She set the radio down. She placed both palms flat on the supply cart. 1 breath. Then she straightened and went back to the monitor. Rate 79. ST segments within normal limits. The inferior STEMI was resolved. The acute event managed, the artery open, the cardiac rhythm stable. He would need the cath lab when the building was clear. He would need a cardiologist's evaluation, and almost certainly an intervention within the next 12 to 24 hours. But the acute event was managed. "Better," she said. Okafor made a sound, something between a breath and a word. "Bay 2. she said to him, without looking up from the chart. The asthma patient. Her SAT has been at 98 for 27 minutes. She can be discharged when the nebulizer cycle completes. Can you start the paperwork? He looked at her for a moment. Then he went to the board. She was updating the TPA documentation. Every timestamp, every dosing calculation, every clinical decision with its rationale in plain language, when Reyes spoke. Halton, he said. Not nurse, not probationary. Her name. She looked at him. He was still at the foot of the gurney, his arms at his sides. His face had the composition of a man who had been very certain about something for a long time, and had arrived at a position that required him to account for the whole of that certainty. You identified the compound by smell, he said. Yes. On your initial assessment, first time you were in that bay. Yes. That was a specific identification, not a guess, not an association. Yes. He looked at the radio, at the ECG, at the thrombolytics tray, at the chart she had been building for the last 58 minutes. 4 months, he said. Yes. He said nothing else. The curtain moved and Staff Sergeant Derek Cho came in. He was 35, compact and specific in his movements, wearing the bomb squad's navy coveralls with the EOD patch on the left chest. He had the look of someone who had completed a technically demanding task under conditions that mattered and was still carrying that focus in with him. He looked at Dorsey. He looked at the ECG monitor. He looked at the radio. He looked at Claire. You're really a nurse, he said. Yes. He studied her for a moment, not doubting it, reconciling it with everything else he had assembled in the last hour. I ran a joint training at Fort Lee 3 years ago, he said. An EOD instructor from Hurlburt Field's 89D program came in as a guest lecturer. She talked about her cohort from the 101st. He paused. She talked about one person specifically. She said there was an NCO who had a specific combination of technical knowledge and operational judgment under pressure that she'd seen once before in her career. She said it was the kind of combination you couldn't train into someone. He looked at her steadily. I'm looking at you, and I'm hearing the same things. Claire said nothing. Cho pulled out his phone. I pulled your record from the DoD database during Device 2. Staff Sergeant Cho reading the file now. He looked at the screen. Master Sergeant Claire Halton, A9D EOD, 101st Airborne Division Support, Hurlburt Field, 2014 through 2023, 3 combat deployments. He looked up. Distinguished Service Cross 2018. Render safe of a 23-pound device in Kandahar with 14 personnel in the immediate blast radius. A silence. The device was neutralized, she said. That's what matters. 14 lives, he said. The device was neutralized, she said again. He looked at the record for another moment. It also notes, Staff Sergeant Marcus Webb, she said. 2022. He lowered the phone. A render safe I initiated, she said. Secondary device. He was in the approach corridor. Her voice stayed level. The after-action review cleared it. The secondary device was a deliberate defensive placement, positioned and timed specifically to target the EOD team after the primary was addressed. The AAR found no operator error. She paused. He was in exactly the right place, doing exactly what the protocol required. I know what that placement means, Cho said. Then you know he was doing his job correctly. She looked at the ECG. He was also the best EOD technician I ever worked with. He had a habit of saying things once and not repeating them. He said that secondary defensive placements were the job's specific cost, and that cost belonged to the device maker and the person who built the trap, not to the person who walked into it on a legitimate approach. She paused. I've been working on believing him. Cho was quiet for a moment. He said what he said the way EOD people said it, direct, specific, not minimizing the thing, and not enlarging it beyond what it was. I'm sorry, he said. Thank you, she said. "There is something I want to make clear before I leave this room," he said. Both devices were rendered safe with no secondary detonations, no personnel casualties, and complete preservation of the device for forensic examination. That is the optimal outcome. It happened because the render-safe procedure was executed correctly on both devices. He looked at her. "I want to be direct about what made that possible. The guidance I received over the radio was specific to a construction template I had not encountered in that configuration. I would have identified the dual trigger. I would have isolated the initiator housing. But the timer lead reversal, the false termination, I would not have known to look for it before I reached it." He paused. "If I had reached the red lead with standard procedure, we would not be having this conversation." She looked at the monitor. "The guidance was accurate," she said. "You executed it. That's the right framing. The guidance was the product of someone who had stood in front of those devices in person," he said. "That's not a small thing." Reyes had not moved. He had been listening to all of it from the foot of the gurney. He was still there. He was listening with the specific attention of a man who was standing in a room and seeing, for the first time, and in the particular way that cannot be undone, what had actually been in it. "Your chart notes," he said. She looked at him. "From the last 4 months. I reviewed them this afternoon before any of this." He did not explain why he had been reviewing them. She did not ask. "Every single one," he said. "Accurate, thorough, and correct." She held his gaze. "I know," she said. "The cardiologist arrived at 7:14 p.m. Her name was Dr. Patricia Wen. She had been in the building when the code silver went out, and she came into Bay 6 with the focused movement of a woman who had received the handoff information in transit and was here to continue what had been started." She reviewed the ECG record, going backward through the timeline. The STEMI on the repeat ECG at 4:58, the escalating rate, the TPA initiation, the progressive normalization. "Administered at 5:43, she said, looking at the documentation. "Yes." "ST elevation on the 4:58 ECG. She looked at the current baseline. "That's a complete response." She looked at Claire with the specific assessment of one clinician evaluating another's work. "Nice management." Claire stepped back. Reyes left when the cardiologist arrived. He paused in the doorway for 1 second before he went. He did not speak. She went to the nursing station. The ER was returning to operational, staff filtering back in, the evacuation protocols reversing, the working sounds resuming. Police and ATF had set up in the administrative wing. Federal Bureau of Investigation had a liaison on site. The hospital's administrative leadership was in the incident command room on the second floor dealing with the institutional dimensions of what had happened. Sandra was managing the board with the focused efficiency of someone who had managed the worst of the evening and was now managing the return from it, which required a different kind of attention, but not a lesser one. "His status?" Sandra said. "Stable. Cardiology is with him. He'll need the cath lab tonight when the building is cleared. Or transferred to another facility if that's not available. And both devices. Clear." Sandra looked at her for a moment. Not with the careful sideways look she had been using for 4 months to communicate things that couldn't be said directly. A direct look. "You should know," Sandra said, "that Okafor went to the evacuation point and told the staff what was happening in Bay 6. The radio exchange, the TPA, all of it." She paused. "I didn't ask him to. He made his own decision." Claire said nothing. "The floor knows," Sandra said. "All of it." Claire sat with Dorsey's chart for 20 minutes, completing the documentation in the specific, thorough way she had been trained in 2 very different programs over the course of a decade. The nursing record was meticulous. Every intervention, every timestamp, every clinical decision with its rationale in plain language accessible to any clinician who would review it. The EOD knowledge she had been using in her memory, the information that didn't have a nursing form yet, would go into the formal debrief with ATF later that evening. She was finishing the chart when Okafor appeared. He stood beside her at the nursing station for a moment without speaking, which was unusual for him. He was a man who typically filled silences with useful information. "How are you?" he said. "Working." "That's not what I mean." He leaned against the counter. "I've been trying to understand something about you since the first week. The way you move, the way you document, the way you're never wrong and you never make it into anything." He paused. "I thought I was watching someone who was very good at nursing and very private about it." "I am good at nursing," she said. "I know. I also know there's a lot more to it than that." He looked at the floor. "What you did tonight, the device guidance, the STEMI management at the same time, the way you just did it. All of it, without announcing any of it." He shook his head. "I've been in medicine for 7 years, and I've never seen anything like that." She closed the chart. "Marcus Webb," she said. "He was my EOD partner for 4 years. He was killed on the last render safe I initiated. The after-action cleared it, but I left the army 6 weeks later." She kept her eyes on the chart. "I took a nursing program, and I took this job, and I tried to be the least visible person on the floor." "Why invisible?" "Because what I was costs things. It costs the people who work beside you. When something goes wrong, the cost is specific and has a name." She paused. "I didn't want to keep paying it forward to people who hadn't signed up for it." Okafor was quiet for a moment. Marcus Webb would have had an opinion about that strategy. She almost smiled. It was very small and very brief. He would have. He would have said it once, with precision, and not repeated it. What would he have said? She looked at the nursing station, at the board with its patient statuses returning to normal parameters, at the floor continuing its work the way a floor that has been doing this for years continues its work. He would have said that being invisible is just a more expensive version of being gone, she said, and that the people you might help don't benefit from the premium you're paying for that. Okafor looked at her. She picked up the next chart. Cho found her in the hallway outside the ATF conference room 30 minutes after the first round of formal questioning. He was out of the coveralls and in his field uniform. He had acquired coffee from somewhere. "They're satisfied with the account for tonight," he said. "There will be follow-up over the next week." "I know. Your name is going to come up, your background, the discharge process." "I know." He leaned against the wall. "I've been talking to the ATF team leader, and to the city's bomb squad commander, and to my chain of command." He looked at her directly. "There's a program in development, a joint initiative between the Army EOD School, the Department of Homeland Security, and a select number of Level 1 trauma centers. The concept is a bridging role, an EOD-trained clinician embedded in a civilian medical setting who provides consultation when explosive devices, suspicious materials, or mass casualty events from explosive ordnance intersect with patient care." He paused. "Like tonight, exactly like tonight." She looked at the conference room door. "The program needs someone to prototype the role," he said. "To develop the protocols, the training curriculum, the integration model for civilian emergency medicine. It needs someone who is credibly both things, the medical and the tactical, and has operational experience in both." He looked at her. "It needs someone who has been in both rooms and knows how to work the two things at the same time." "I've been working very hard at only being in one room," she said. "I know." He was quiet for a moment. "I read the Webb AAR. I read it twice. The conclusion is what you said. The secondary device was a deliberate defensive placement specifically designed to target the EOD team after primary render safe. It was a trap built by someone who understood how EOD operates and built the device to defeat the procedure." He looked at her. "You know that. I know it. But knowing and living it are different." "Yes." "Webb was doing his job correctly in the right position at the right time," Cho said. "The after-action said that. I'm saying it too. The cost of that render safe belongs to the person who built the trap. It doesn't belong to you." She looked at the hallway. The program is voluntary, he said. Structured as a consulting engagement, not a return to active duty. You stay in nursing. You stay here if you choose. You add the bridging role alongside what you're already doing. He reached into his jacket pocket and produced a card. You stop being invisible. She took the card, held it for a moment, turning it once. Marcus had said things once and not repeated them. Who had known on the approach in 2022 exactly what the situation required of him and had moved toward it anyway. Not because he was unafraid, she had known him long enough to know the distinction, but because he had a clear assessment of what mattered most, and he had built the habit of acting from that assessment, regardless of what the assessment cost. That smell she had walked into at 4:31 that afternoon. The granular residue. The jacket zipped to the collar. The note she had written and watched be deleted. The 14 minutes between the deletion and the code silver. Dorsey on the gurney. On the gurney saying I didn't think about the hospital when I planned this. I was supposed to be home. The ECG on the monitor, the ST segments rising and then, over the course of an hour, retreating. A clot dissolving. A coronary reopening. Her hands had known exactly what to do. They had always known. I'll review the program structure, she said. Cho nodded. He handed her the card. She put it in her pocket and went back to the floor. Dr. Reyes was at the nursing station. He was reviewing a post-evacuation chart update with Sandra, and he looked up when Claire approached the desk. Sandra gave her a brief look that communicated several things and went back to the tablet. Reyes put down the chart. Probationary status removed effective today, he said. Paperwork in the morning. She looked at him. He looked at the nursing station, at the board, at the floor returning to its rhythm. Why didn't you? He started. Tell you, she said. Yes. Because you didn't ask, she said. You decided. In the first week, you decided what I was, and you spent 4 months maintaining that decision. She picked up the next chart. I'm telling you that, as a matter of record, not as a complaint. The record is accurate. He looked at her. He did not argue. He turned and walked back toward the surgical wing. Sandra appeared at her shoulder in the silence that followed. He's going to think about that for a long time, she said. He might. He will. Sandra looked at the floor, at its normalcy, at its people doing the work the way they had been doing the work all evening and would continue doing it. You know what I've never seen in 11 years on this floor? Tell me. A floor that ran better in a crisis than it does on a normal Tuesday. She looked at Claire. That's what tonight was. Claire went to her patients. Bay 2, the asthma patient, sat at 98 for 40 minutes, ready to go home. She finished the discharge paperwork with the precision she brought to everything. Bay 9, post-procedure, uncomplicated, waiting on the final clearance note. Bay 11. Thomas Garrett was awake and watching the news coverage on his phone. The hospital was already on the local stations. Aerial footage, police tape, the specific visual language of something significant having happened here. His pressure had held at range throughout the evening. He looked up when she came in. I hear you had quite a night, he said. Busy shift? Nice way to put it. He watched her check his blood pressure. 133/80. Excellent. I could hear some of it through the wall, when the frequency was open. She made a notation. Army, he said. Not a question. Yes. EOD? Yes. He was quiet for a moment with the look of an older veteran placing a younger one, not assessing, recognizing. My son is medical, he said. Fort Sam Houston. He says the EOD people are the ones nobody talks about until something goes wrong, and then everyone talks about them. He paused. He means it as a compliment. It's accurate, she said. She updated his chart. She called the consult department and rescheduled his delayed consultation for the following morning with the specific language that got it appropriately prioritized. She was heading back to the nursing station when she passed Bay 6. The curtain was drawn. Dorsey had been moved to the monitored cardiac floor while she was in the ATF debrief. Dr. Wen had made the call when the building clearance came through. The bay was reset. The gurney was clean. The monitor was cleared. She stopped. The empty bay. 4:31 that afternoon. The smell she had walked into and named immediately. The residue under the nail. The jacket in 72-degree air. The phone face down after the signal arrived. The note she had written in careful clinical language and watched be deleted from the record as if the knowledge behind it did not exist. What had been possible tonight because that knowledge was present, and what it had cost to have it treated as nothing. The card in her pocket. Marcus, who had said that being invisible was just a more expensive version of being gone. One more second looking at the empty bay. Then she turned and went back to the floor. She had patients to see, and documentation to complete, and a program structure to review, and the fluorescent lights of Prescott Medical Center were running at their usual register, and the monitors were beeping at their usual frequencies, and the work was what the work always was, continuous and specific and necessary. She was exactly what she was, not despite it, because of it. She picked up the next chart and got back to work. The person who has already been through the worst is never who you think they are. They are exactly who you need them to be.